that future. Lastly, I do want to thank all of those who organized this event. This is our second year, and we're very, very excited about that, and we're going to try and make this an annual event. And I think that the speakers we've attracted and the conversations we're having is truly very, very important. So thank you all for being here. Thank everyone who organized this, and enjoy the rest of the day. Thank you.
Given the very daunting task of summarizing yesterday's meeting, and I don't think I really can begin to do it justice, but for those of you who maybe missed some of the sessions yesterday, and of course they'll be available on video, I'll just give you a really brief overview. So our first session was on conception, and I have to say, as somebody who hasn't thought about blastocyst development since medical school, it was extraordinarily eye-opening. So Magda was our first speaker, and she presented really what was truly a paradigm-shifting heterogeneity model for blastocyst development. And after that, we had Dr. Para, who told us about some very innovative software technology to assess blastocyst viability. And finally, Gary presented some of his pioneering work on embryo selection. So set the stage really beautifully. We then we're very fortunate that Michael Liu joined us as the chief of the Maternal Child Health Bureau, or DAHS. And it was so impressive and so inspirational how his office has truly moved the needle substantially across the country across the full spectrum of maternal and child health, and really has lived up to the vision of that bureau. We then moved on to a session on development to term, which really highlighted much of the work that's been done here in the Johnson Center and at the hospital more broadly. And Gary Shaw presented really very impressive and state-of-the-art epidemiology work on epigenetics, and it's quite impressive how his group has advanced our understanding of risk factors for prematurity and risk factors including environmental gene interactions for premature or for birth defects and for prematurity. Bryce presented some very impressive new technology, the CyTOF time-flight CyTOF technology on the predictive immune signatures, which I think is going to really present a great advance, and he'll come back, I'm sure, in the future and tell us more about some of the longitudinal studies and the work that they're doing there. And then Virginia Wynn pulled it all together with an explanation of the complexity and of the placenta as an endocrine organ, with her work on extracellular vesicles and the whole idea of the communication between the mother and the fetus. And finally, Ann Lynch presents a new proteomic analysis. And to me, much of the way the work is done in the volcano plots was really very eye-opening in terms of biomarkers. And not only that, but really identified a number of pathways related to complement, immune function, and clotting. Then we moved on to talk about the sequelae of the fetus that's born too soon. And Carl not only told us about his work in necrotizing enterocolitis, but helped us think about the way newborn screening can be repurposed for acquired diseases, and I think that's going to have an impact far beyond the work in the premature infant. Hugh, our chair, told us about his population-based studies and the genetics of lung development and the advances using more sophisticated genetic methods than just GWAS. And finally, Heidi presented an extraordinary integration of novel and traditional behavioral techniques with state-of-the-art advanced neuroimaging. And I can't remember the name of the neural pathway that was her favorite, but it was really a very captivating presentation. And then finally, which was perfect for Stanford, was a presentation on technology and innovation, and Tom Insel presented a very comprehensive talk on the revolutions in neuroscience and the notion of the connect-home genomics and technology. Alan Flake, who's a surgeon, presented his work on the artificial placenta, which referred to as Extend. He's an old colleague of mine, and the last time I saw that work in a steel mesh sort of hammock hanging in a fish tank, and it was quite exciting to see how they've advanced, that technology's advanced, and how they're really able to put forth the utility of this sort of technology for the fetus that unfortunately is viable but really is just born too soon, and how that's going to provide a very important bridge. And then finally, Paul Jacques from the Biodesign School picked two of what I'm sure are many examples of how the Biodesign Group is doing innovations in perinatal care. So obviously a very, very impressive and exciting spectrum of work. So on that note, or moving on, it's my pleasure to introduce Bonnie Maldonado, who will moderate the next session. Thank you.
Welcome, everybody. Good morning. And thank you for attending the second day. We're very excited to have you here, and we have a really wonderful session for you this morning as well as after this. So what I want to talk about today, and I'm the moderator for the next three speakers, we want to talk about a population that isn't human and a population that aren't children. So why are they important to us? Well, these are important because these are the microbiomes, the bacteria and the viruses that live around us, that probably live within us, most of these, and the people who have been studying these, in fact, some of the people that we're talking about today have done groundbreaking work in the area of understanding how these organisms live with us, live within us, live outside of us, and how they affect maternal and fetal health and the life course of the human being. And so to start off, I'd like to introduce Dr. David Relman, who's the American Professor of Medicine and Microbiology and Immunology. And he is one of the pioneers in the area of the discovery and the definition of the human microbiome using his advanced molecular techniques over the many years that he's been here at Stanford. And so thank you very much, David.
It's a pleasure. So it's a pleasure and honor to join you here this morning. Bonnie already introduced the concept that much of us, in fact, is not of eukaryotic origin. And so that's going to be the theme of much of what I will talk about, and in fact, the subsequent two speakers. The topics I thought might be of interest and relevance here are premised on concepts that ecologists have spoken about and studied for quite some time. And for that reason, I thought I would talk about ecological landscape as a nice starting place. Ecologists also were quite interested in the role of history in determining the subsequent structure and functioning of the microbial communities that they study, and in fact all communities that one might study. And so that too is something that I want to touch upon because, in fact, we are very much about our history as well. Third, much of life is about the exposure to and recovery from disturbance. And I thought I would introduce that concept in the context of pregnancy and think about with you whether pregnancy ought to be viewed as a form of disturbance to which we have, of course, adapted over time. States of stability in a complex system. Many have been drawn to this imagery of the topological landscape, the idea of a surface. It's drawn here in two dimensions, but you might think of it in three, which has in it a number of different valleys, depressions of varying depths. Those depressions are meant to signify, in this case, a stable state. A state in which a community ecosystem may find a great deal of robustness and resistance to change. So the deeper this valley, the more stable would be the system. And you can see these systems depicted as little interactomes, the networks of interacting organisms, and they're interacting with an environment as well. There are, of course, multiple stable states, and the landscape, the shape of this landscape, determines the likelihood that a given state will remain as is or be subject to change. Now, this landscape in this setting today, in these discussions, is us. And so as clinicians, one of the goals might be for us to be able to describe the landscape, the topological landscape, which is each of our patients or anyone that we seek to understand and help manage in the form of their health. And so I'll talk a little bit more about why that may be an important way of thinking about the human microbiome, the collection of organisms that come together and have co-adapted with this host, us, and form these communities, and then the subsequent states that they occupy over time. Just to remind you, we now have a great deal of building data and evidence that suggests that the microbial communities of the human body are inextricably involved in some fundamentally important biological, physiologically, clinically relevant processes that underlie all that we are. So, ranging from digestion to nutrition to the early instruction of our immune system, the processing of foreign compounds, xenobiotics, the management of our exposures to all sorts of day-to-day and varying kinds of change and disturbance. So this is all that we are come to know to be important about our microbiome. And needless to say, much of this might be seen as directly relevant to the time of life that I'm going to talk a little bit more about, pregnancy. Pregnancy is, of course, important as the historic backdrop, the preceding state in time that may, in fact, be so important in determining the nature of the microbiome that's presented to a child at birth. And yet, we think less about the microbiome of a mother when we're worried and thinking about what is the role of a microbiome in a baby and what might it bestow upon that baby in terms of future health and possibly susceptibility to disease. There are a number of ways of thinking about this history prior to birth and its relationship to the microbial communities, the microbiome. One is to think more about what are the states of maternal health during pregnancy and how might they affect the mother's microbiome, which in fact will be the microbiome that is transferred to the baby, at least in part, for some period of time. What about the changes that take place in a woman at the time of conception? We know essentially nothing about the effect of conception, the onset of pregnancy, on the maternal microbiome. What about the subsequent exposures of the mother during pregnancy? Diet, drugs, intercurrent infections. These are all things we know to affect microbiomes. We've studied very little of this in the setting of pregnancy. And yet there are some important theories and concepts that would suggest that we ought to be looking carefully at these various factors, this history in the mother. This is a review that's published by a colleague here at Stanford, Tatsukami,